Hello and welcome to Utano Podcast. Let's talk about health in Africa. A podcast exploring ideas, systems, approaches, and people shaping the future of health innovation and patient care across the African continent. I'm your host, Lenias Hwenda. Every breakthrough, no matter how advanced, ultimately succeeds or fails on one metric: patient safety. Today's episode focuses on a principle that should guide every health breakthrough and policy decision: this issue of patient safety. As Africa expands its footprint in clinical research, digital health, and medical devices, as well as regulatory reform, we must ask ourselves this: are patients truly at the heart of innovation and regulatory decisions, or are we leaving them behind? Around the world, governments are making a shift. After decades of patient safety initiatives, some governments, like the UK government, are now creating an independent patient safety commissioner. This conversation is inspired by the work of the UK's very first patient safety commissioner, Professor Henrietta Hughes, who is joining us today to discuss whether giving patients an independent voice signals the future of patient safety governance. We explore what it means to put patient safety at the heart of innovation and what African health leaders can learn from global best practices. So why now? What has changed? And what problem does this model try to fix? We explore how giving patients an independent voice in safety governance changes the power balance between patients, regulators, industry, and health systems. Professor Hughes, welcome to Utano Podcast.
Well, thank you so much for inviting me to take part in your podcast. It's fantastic, and I'm delighted to be able to talk about some of the work that we've been doing here in the UK and how that benefits patients and those who look after them as well.
Wonderful. So let's start at the beginning by talking about what it means. What does it mean to put patient safety at the heart of innovation?
Well, my role in England as the first patient safety commissioner in the world is to promote the safety of medicines and medical devices and the value of listening to patients in that regard. Because when we work with patients as partners, we can see the benefits not only in improved safety, but better outcomes, better experience for patients, and it's also more efficient and more cost-effective care because we don't have to have additional care needs, and it avoids the need for complaints and litigation as well. So I think that putting patients at the heart of everything we do, whether that's innovation, policy, regulation, and also clinical practice, has got to be the right thing. And last year, in 2024, actually, I published the Patient Safety Principles, setting out how we can make decisions that include the patient's perspective. And these have now been widely adopted across different organizations in the UK.
So patient safety isn't just about actually avoiding harm. It also serves health systems money. It helps to make healthcare more cost efficient and builds confidence and dignity. Now, let's talk about why you in the UK. I presume this is not something that is widely done, having a patient safety commissioner. Why in the UK have you arrived at this decision of having an independent patient safety voice? And what got you to this place?
Well, unfortunately, it started because patients weren't listened to and were harmed as a result. And three groups of patients, mainly women, who'd been harmed through the use of vaginal mesh, which was a treatment for incontinence and pelvic organ prolapse, valproate, which is a treatment for epilepsy and some mental health conditions, and also Primodos, which was used as a hormone pregnancy test. These patients and their babies were harmed as a result of their treatment. And a member of our House of Lords, Baroness Cumberledge, was tasked with understanding what had gone wrong and what needed to be done differently in the future. And she made a series of recommendations, and one of those was to have an independent patient safety commissioner to act as a champion for patient voice, to work with government, with policymakers, and with the health system as a whole, to remove some of these barriers to listening to patients, to promote safety, but also to get ahead of harm and bring together a very complex, disparate, siloed health system, really around the needs of patients.
Yes. So what changed really wasn't the lack of data, it was the accumulation of lived experiences of patients and the harm that the system, with the frameworks that it had in place, wasn't able to prevent or to redress, whilst these things were going on.
Well, these patients had experienced harm because of the fact that the regulators hadn't put the right things in place to protect the patients and their families. The doctors and nurses who were looking after them didn't listen when patients said that they were experiencing harm, or when that their babies had been damaged after being exposed to medicines. Yes. And because the healthcare system needs to work together, we found that there were real gaps in the way that patients were being treated. So the way that my role works is to work with across the whole healthcare system to start understanding what causes problems, who might own parts of those solutions, and then bring people together around the problem to really get things better for patients. And with the conditions that I've discussed, one of the examples that I can give is that we saw a change in the law around making sure that patients were always given their medicine in its original packaging. We'd had a previous situation where the medicine might be broken up into different boxes and given to patients in plain white boxes, and then it didn't have all the right information for patients, so that when they were taking the medicines, they didn't have the full information they needed. So by working together with politicians and with patient groups and really escalating the patient's concerns right into the heart of government, we've been able to see some really important structural improvements being made. One of the examples that I can give is around a policy which I led on, which is called Martha's Rule, which is about the ability for patients and families in hospital to be able to request a rapid review from the critical care outreach team if they feel that the team that are treating them haven't really been listening or haven't taken on board their concerns. Because we know that patients and family members are the real experts of knowing their loved one the best. And sometimes when somebody's in hospital, it's harder for the staff to be able to know what they're normally like on a good day. And this arose from a tragic death of a young girl, a 13-year-old girl who died of sepsis because when her condition was deteriorating in hospital and her parents were flagging the concerns, and Martha herself was flagging concerns, that the staff weren't taking those on board and weren't getting the right assessment or review done. But we've now got Martha's Rule across the whole of England. So in every hospital, if you are a patient in hospital, you can pick up the phone if you're concerned. And we know that over 8,000 calls have been made since the policy was established in England.
Wow.
And what's been really amazing is that 3/4 of those calls have come from family members. And as a result, hundreds of patients' lives have been saved because the right intervention has been made. And thousands of others have avoided worse deterioration of their symptoms as well. So it really shows the staff and the family members that their voices really matter, that they have the authority to pick up the phone, but also that it can really lead to improvements. And it's not a blame or an antagonistic way of doing it. It's about working in partnership with patients and families. So these are the kind of cultural shifts that we're looking to see in England, and bringing in expertise from across the world, with the, real sort of inspiration from Australia with Ryan's rule and from the USA with Operation Help. So I do think there's real opportunities for learning and sharing from different health systems to make things better for our own patients.
Great interventions that are really bringing meaningful impact after such tragic cases like the young girl Martha that you're talking about. And it sounds like something that could have been entirely preventable. But are there persistent failures that you see that are going across the board, whatever the discipline is that you see, that this model or this approach that you're taking in the UK is able to address?
Well, what I think is really interesting is that nobody goes to work to do a bad job, but the system that we work in, it doesn't always support listening to patients. I don't think modern healthcare systems are really designed for listening to patients. It's much more about, what does the diagnostic say? What does the scan say? And I think the other thing that I was going to say is that because healthcare can be really fragmented between what's happening in the patient's home or in primary care, in the hospitals. And, sometimes information gets lost between those gaps. So part of this is about looking at systems that help support safety. So whether we're using electronic patient records or robotic medicine dispensing, the more that we're able to put the structures in place that stop human error and the gaps of information, the better. I mean, not everything is about high tech, though. A lot of this is about having that time, having that that philosophy, really, of bringing the patient into the conversation, really asking those important questions like, what matters to you? What are your ideas? What are your concerns? What are your expectations? And ensuring that when people are planning treatment, that they're given the right information to be able to consent. These are really fundamental issues. And as part of the patient safety principles, we've set these out around having a safety culture, putting patients at the heart of everything, looking at risk, looking at equity, because this is a really important area. You may be aware of the controversy around pulse oximeters and the fact that they don't work so well for people with darker skin tones. How do we make sure that when we're procuring products that we're thinking about equity, how do we make sure that the staff understand the limitations of devices that they're using? But also, how do we make sure that patients really understand that, if they're not feeling well, even if the machine says they're fine, that they've got the, authority and the empowerment to be able to speak up. So this is a really kind of multifaceted cultural issue. But I'm really excited the fact that when I've made recommendations, a lot of time I'm pushing on an open door. But we track the recommendations to make sure that they get implemented in the system so that the change becomes sustainable, that it becomes, really fundamental, and that patients can feel the difference. So if I was just going to give you an example, we work with 2 health charities who support people with vision loss and hearing loss, because we know that patients who've got poor vision or poor hearing, they really struggle with medicines and medical devices. So again, bringing in different voices, working with the health system, and really looking to see improvements in that sense.
Very remarkable and indeed very exciting, Prof. Hughes, because what you're doing, what it sounds like to me, is that you're really now designing patient safety into the system, into the processes, so that it's well integrated. It's not an afterthought. When patients are receiving care, and all of this, the approach of integrating charities that are working with people with disabilities and so forth. It's really creating a system and architecture for safety. And I think that's interesting and exciting for others who are looking at your system and looking and thinking, what is it that they could learn? But you talk about fragmentation in this system, and usually this is part of the big challenge. Traditionally, patient safety is spread across regulators, providers, professional bodies, and so forth. Everybody is responsible, which often means nobody is responsible, and you're changing that. So that's very interesting. Now, maybe you can talk a little bit about whether you think this can really change the culture and behavior, because ultimately that's what it is, right? Do you feel that, this approach is changing the culture and behavior across the NHS?
Well, I think that what I'd say is that things in the world are changing rapidly at the moment, and it wouldn't be right if I didn't mention AI and healthcare. So in the UK, we have a National Commission for the Regulation of AI in Healthcare. And I'm the deputy chair of that commission. And what I'm really interested in is how regulation is traditionally slow, consensual, and national, whereas AI is none of those things. AI puts empowerment into patients' hand, but it can also provide misinformation. So when I think about how patients seek healthcare, if it's not accessible and it's not easily available, people will take matters into their own hands. And we've seen this, for example, in the UK with people, seeking GLP-1s and obesity medication from the private sector, because the NHS isn't making it available to people who want it. So when it comes to things like AI, if you've got, an app in your pocket that is going to be able to answer questions, give you the right information to be able to have a different conversation with your healthcare provider, how are we in the UK, but also across the world, preparing for this? Because culture shifts can happen incredibly quickly. And I think what's really important here is that we build a regulatory system which isn't in isolation to the rest of the healthcare system, that it has to be principle-based, it has to be flexible, it has to be agile to cope with the future. And when I think about the work that we've done on other medicines and medical devices, really thinking about start with the patient and then build the system around it, then we are getting to a place where the healthcare system is doing what it's there for, which is to help improve the health of the nation and help improve people's lives, when they become unwell. So I think that when it comes to culture can move rapidly, not necessarily at a pace that everybody feels comfortable with. But if we start with the principles and start with the purpose of why healthcare professionals went into those professions, why people want to work in healthcare organizations, and particularly in terms of the healthcare regulation. And remember, this is about patients, and patients are also the citizens who are also funding the healthcare system. I think that's a really different conversation, and it's a much more empowering one. But it's not about saying we get it right for patients and worse for the healthcare professionals. It's about getting it better for everybody and doing that in a way which builds relationships, avoids that kind of fear culture, the culture of cover up, and actually recognizes that everybody has got a part to play in improving patient safety.
Making it better for everybody, which means equity, basically more equitable healthcare. Now, in cases where, obviously, you want to have this system that is accountable, that is open, that is collegial in the way that you're tackling these problems. But I'm sure things still do go wrong from time to time. How does having a statutory independent commissioner change the accountability and the way issues are escalating, bearing in mind that you want to move away from the blame culture, which tends to provoke people to want to cover up when things have gone wrong?
Well, you've hit the nail on the head, because one of the principles is about transparency and accountability. And I think that the transparency and accountability are things that people will often say that they do, but actually fear can sometimes shut people down. And so we work with the different parts of the health system to think about where's the liability, where does the liability sit, where is the, how can we use the information from where things have gone wrong in the past to improve things. Another one of the principles is about using data and information to
Yes.
improve outcomes. So why is it that you have a problem that happens in one hospital and then maybe a year later the exact same problem happens in another?
Yes.
It's because we're not sharing information, we're not bringing information to the forefront so that that can then make improvements in the future. When it comes to things going wrong, I think what's really important is that patients get the full information that they need. That we know that in the past, people haven't always been given the full information. And what was described, we have a duty of candor in the NHS. And what was described to me was the difference between honesty, which is not telling a lie, and being candid, which is telling the whole truth. I think that's where that real difference comes in.
So really, one of the things you mentioned there in your explanation is how healthcare systems are not fully utilizing the resource, the powerful resource of the patient's lived experience, which leads to perhaps similar mistakes being repeated across different healthcare institutions. And you talked about data. Now, how can patients' lived experiences help to prevent harm and improve healthcare systems? How do you embed that, into a system like this to really change how it works and bring that sustainability aspect that you mentioned, that it has to be sustainable?
So I think there are three elements which make a really big difference. The first one is about leadership. This is about leaders being intentional, really understanding the experience of people using their services by speaking to them, board meetings, listening to the outcomes and the accounts from patients and families, but also using feedback data, whether that's numerical or, the free text comments are often the most interesting. And we can see that in organizations where patient feedback is used, that you get that positive response back to patients. Their morale improves, their outcomes are better, and the staff morale improves as well. And in organizations who don't respond to patient feedback, you see the opposite. You see people not feeling heard, going to their political representative or to social media or to the press. The staff morale is worse and the outcomes are worse. So the leadership aspect, I think, is absolutely key. The second element is about creating opportunities for listening. And that should ideally be in the hospital at the patient's bedside. And what we found with Martha's Rule is by asking the patients in hospital every day, how do you feel? Do you feel good? Do you feel bad? Do you feel better or worse? Simple questions, but giving people the opportunity to say, I don't feel so good today, and then acting on that information. And then the final element that I'd say is that it's about the sort of really listening with respect, so that we take everything that the patient says as important as what the doctor is saying or the nurse is saying or the academic is saying, because randomized controlled trials are great for understanding benefit. But when it comes to understanding harm, you have to flip that on its head and say anecdote is the most important. So we shouldn't dismiss patients' experience as just merely anecdote, which is very low in the hierarchy of evidence. Actually, it's the most sensitive. It is the most sensitive when it comes to understanding about harm. So by educating people all the way through their careers, from student all the way to academic or senior leader, we should really be able to bring that in, that when a patient says something is wrong, we should be absolutely listening and attending to it as well.
Indeed. Listen early, not after harm, and take decisive action, not endless inquiries afterwards. Now, let's talk about the factors that could constrain the impact of this approach that you have taken in the UK, which I think is a very powerful model. But there is no model without limits, right? No model is without limit. What kind of factors or constraints, tensions that you see that could limit the potential impact of an independent commissioner being able to really transform this?
Well, I think that, in terms of resources, I have a very small team. In fact, it's me and one other person at the moment. And so we, have to work with and through others. I don't have an executive function. My role is to suggest, encourage, recommend, cajole, persuade, and then to really track this through until I can see my recommendations have been implemented. I think it helps that I'm a doctor, that I'm still practicing, and that I've worked in different parts of the healthcare leadership system as a medical director. And in my previous role, I was the National Guardian for the NHS, where I set up Freedom to Speak Up Guardian Network so that staff members could speak up. So when it comes to having the connections across the healthcare system, the relationships, and also an understanding of other people's strategies and their goals as well. So I could just sit in a room and do nothing, but I'm out and about meeting people, listening to patients, listening to staff, and then really thinking about what changes need to be made to policies, procedures, laws, and regulations. And so that to me is very much about if we had that same approach of people being curious, having conversations and thinking together about what changes need to be made, that could be happening in any healthcare setting. It doesn't need a patient safety commissioner to catalyze that.
Now let's flip that on its head and talk about the conditions that are needed to really make this succeed, and whether these conditions are likely to be different in different countries. If you imagine resource limited settings, for instance, is what's required for this independent commissioner's office to succeed at bringing that culture change, better protecting patients, likely to be different depending on the context?
I think all countries have the same, or I've heard from patient groups across many countries in the world where the patients haven't been listened to. So I think this is a global phenomena. But what I think is really different is about the cultural context. So in some parts of the world, the idea of a nurse challenging a doctor is just unthinkable. And a patient challenging is just unheard. So it's really very much about, helping, I'd say, on quite a small scale, but also at national scale, an idea that, this is something that we want to see done differently. This is not about removing the privilege or the knowledge or the expertise from clinicians. This is about opening up our minds and opening up our hearts to really understand what's happening with our patients. What I was going to say that really is an important aspect of my role is its independence. That I'm appointed by the Secretary of State for Healthcare, and I'm accountable to our Parliament. I publish an annual report which gets laid before Parliament. I have an independent website. I have an independent strategy. I have an independent social media. So I think that's a really important aspect of this, because although, I work closely with many different parts of the healthcare system, I'm able to bring a very independent voice to that conversation.
Absolutely. And healthcare is getting so much more complex everywhere. And so what I'm wondering is whether this is the future of patient safety governance, because you just talked about, how conservative and how, like the idea of a nurse challenging a doctor is unheard of anywhere in the world, right? And so changing those practices, those ways of doing things seems quite critical. And I think, anywhere to imagine that, well, one morning we'll wake up and nurses are able to just say, no, doctor, I don't agree with your decision, and challenge them, is probably not very realistic. Do you see this as the future of patient safety governance if we really want to be able to drive that change that's needed to make patient safety better?
So I know this sounds quite radical, and I'm, as a doctor myself, I have some insight into the fact that if I am suggesting something, it will come with a different weight than if somebody who wasn't qualified would say
Right.
something.
Yes.
There's a term called epistemic injustice, and
Yes.
that is the injustice of knowledge, of status, and of language.
Yes.
So what that means is that I might be having a conversation with a clinical colleague, and we'll be using technical language, jargon, and that's normal in any profession. There's a jargon and a technical language, but it doesn't mean that we should be using that when we're talking to people who don't have the same training and skills as us, because that's just about not recognizing that the purpose of communication is for the person to understand what we're talking about. So when we think about, for example, when a patient is consenting to treatment, we need to put this in the language that is meaningful to that individual. Otherwise, they're not fully informed.
Yes.
So when it comes to Martha's rule, what's been really interesting is that other members of staff can pick up the phone, not just patients and families. So we've had, staff on the ward picking up the phone, and that includes nurses and others, maybe healthcare assistants, housekeepers, porters, anyone who may have a concern about the patient's condition.
Right.
And they have an even more sensitive, recognition of deterioration than the family members themselves. So what's been really interesting is about flattening the hierarchy, and how does it feel for the doctor on the other end when somebody else has picked up the phone and asked for a rapid review?
Yes.
Well, it can feel crushing. It can feel like you've let yourself down, that you're not a good doctor, that you haven't listened to your patient. And actually, we've heard from doctors who have had that experience, and they even though they've been involved in the development of the policy, they actually found it a really demoralizing experience when one of their patients, I think, or a staff member, picked up the phone. What I'm trying to get past that is to say, it's better that somebody picks up the phone to help you than that the patient dies and then you're involved in a coroner's court, or you're involved in an incident, or somebody litigates. And the harm and the intergenerational harm that can happen for that family. But also, we know that staff can sometimes really have terrible consequences on their well-being and career as well. Obviously nothing as bad as what happens to a family if somebody dies, but it's just a negative aspect all the way through. And what I'm trying to say is, if we can nip that in the bud by having that person picking up the phone and saying, I'm not really happy about this patient, and getting some help, see it as help. Maybe healthcare professionals, we're not very good at asking for help. And sometimes we feel it very keenly when it looks as if we've failed. Let's get past that. Let's be mature and let's accept the fact that if we work as part of a team with patients and with our colleagues, then we'll get the outcomes that we're looking for, the outcomes that are right for our patients. They should be the ones that are right for us as well. This is a big cultural change. And I recognize that not everybody's in the same starting place. So I'm very mindful of the fact that some people are more able to kind of come on this journey than others.
Yes, I think it's a perspective that with time, as this system evolves, perhaps people will come to that understanding that actually when somebody raises a flag, we're actually pulling for the same team. We are working towards the same objective, and that's not necessarily a bad thing. But yes, I can appreciate how it can sting to be the subject of such a flag raising, if you like. Now, let's finish by talking about global best practices. It occurs to me that the way that you have thought about this system, trying to build in safety, patient safety into your healthcare architecture, into your mindsets, into your culture, really seems to be a really good way to go in terms of addressing some of the challenges that gets in the way of patients being heard. So what lessons do you think, I'm sure you've learned a ton of things since you have started taking this approach. What lessons can African regulatory leaders, health leaders learn from some of the best practices that are coming out of your systems, the things that you're learning, what works and what doesn't?
Well, I would first of all start saying that, every system needs to deal with things in the right way for them. And there's no advantage in saying, oh, take this and do it exactly the same way. Like I said before, we took Australian, we took American, and we brought it together and found something that works for England. But at the same time, if I was going to refer back to the patient safety principles, these principles feel quite universal to me. And they may be helpful in terms of looking at the corporate strategies of the healthcare regulators, of the healthcare providers. And we've been working with our regulators and providers and politicians to really think about how the patient safety principles can be used as a framework for assessing policy, for looking at legislation, for looking at processes. And so there's a real opportunity there, I would say, to have a look at those, see whether they need adapting to, a local context, but also to use them as a way of saying, look, does our policy, where are our strengths? Where do we have to look a little bit harder? Are we using data properly? Have we got the right transparency? How do we bring patients to the heart of everything that we do? So by doing that and having a look at things from the beginning, rather than in the after the event space, thinking about things up front, and then building that into education, building it into training, and the way that we go about things, the culture, the way that we work. I think that to me is something which it doesn't rely on high tech. It could happen. It could work in any setting, in the patient's home. It could be happening in a local healthcare setting, or looking at national policy. I'm also really interested, if people do want to use the principles, to get in touch with me and let me know, because I'm really interested in to see how we can help support improvements, not only in England, but also working with global partners, and really understanding more about, how we can learn from their experience as well.
Thank you for that invitation, that if other healthcare leaders, healthcare providers are interested in looking at these principles, adapting them to their own systems, you're very open to collaborating to see how you can leverage your experience to help others improve elsewhere. I think this is really powerful, and I hope that we can continue to have this conversation about patient safety, because it's really the bottom line. Why healthcare systems exist, why they do what they do. It's about patients, and keeping them safe seems like the most sacred duty of that system. Professor Hughes, thank you so much for coming onto Utano Podcast.
Well, thank you so much for having me. It's been a real pleasure.
One key takeaway for me from Prof. Hughes is that patient safety thrives in systems that are built on transparency, on accountability, and listening. And regulation can, of course, enable trust. So putting patient safety at the heart of innovation ensures that every breakthrough serves the people that it was meant to help. Thank you for joining me, Lenias Hwenda, on Utano Podcast. And until next time, let's keep talking about health in Africa.